The final module for this course is about clinical management of post-COVID conditions. In this module, we will briefly cover management strategies for patients with post-COVID conditions. Next, we will review clinical and pharmacotherapy for POTS, vestibular syndromes and symptoms, post-exertional malaise, and brain fog related to post-COVID conditions. There is a general approach for healthcare providers to follow in order to give adequate supportive management to their patients. First, addressing all other conditions besides the post-COVID condition is important to treat patients holistically. Second, pacing activities in order to prevent symptom escalation, whether it be for post-exertional malaise, POTS, or other post-COVID conditions that can be exacerbated through significant increases in activity. Third, addressing the major aspects of illness and well-being that the patient is experiencing. When taking a more proactive approach with clinical management, it is important to consider where the patient may be experiencing symptoms and to treat each symptom individually. Choosing medications that can treat more than one symptom can be important to minimize the number of interventions needed to improve patient symptoms. This diagram shows how using fitness, emotional well-being, restorative sleep, and pain management work together to improve overall well-being. The first post-COVID condition we will discuss is the clinical management of POTS. As presented in Module 1, POTS is a type of orthostatic intolerance, and just as other orthostatic intolerances like orthostatic hypotension, it is both measurable and treatable. The key to treating these conditions is to focus on prevention and to address each symptom. Unfortunately, there is currently no single drug that can take away all of these symptoms. Since symptoms of POTS are triggered by a decrease in intravascular volume, it is recommended that the first intervention should be focused on increasing fluid and salt intake to ensure that patients have appropriate blood volume. Fludrocortisone can be prescribed for orthostatic intolerance as well. It is a synthetic steroid that encourages salt retention and therefore water retention to keep fluid volume up. After symptoms have already occurred, rapid water ingestion of either 16 ounces of fluid or using IV normal saline can be used to increase fluid volume. Both of these can decrease symptoms if used shortly after starting. Low blood volume is sensed in blood vessels through pressure receptors. Therefore, it is also possible to have interventions that directly compress or constrict blood vessels. This includes compression items that will externally compress blood vessels and also medications such as midodrine that can cause constriction of the blood vessels to increase blood pressure. The rapid heart rate or tachycardia that occurs with POTS can be controlled with low-dose beta blockers that will block sympathetic signals to the heart. Pyridostigmine, a drug that increases the neurotransmitter acetylcholine, can also increase constriction of blood vessels and increase venous return back to the heart. An intervention that is often overlooked is strengthening and using the body's muscular pumps for better venous return. Strengthening the muscles of the legs and abdomen can be used to increase blood flow back to the heart against gravity. There are a variety of other pharmacological treatments that can be used to address orthostatic intolerance that work through different mechanisms to treat symptoms of POTS. It is important to have a provider that is knowledgeable of these treatments in order to prescribe a multimodal treatment regimen that will best treat the individual with POTS. Drugs that should be used in caution are ones that act to increase sympathetic conduction pathways because these drugs can worsen the symptoms of POTS. The clinical management of vestibular syndromes and symptoms is the next post-COVID condition that will be addressed. The vestibular symptoms associated with post-COVID conditions are difficult to assess and treat. Diagnosing vestibular symptoms can require a series of complicated tests and exams. There has been clinical evidence that performing head movements in conjunction with progressive standing balance exercise can improve patient functional mobility and decrease dizziness. In most situations, it is recommended to refer these patients to ENT and audiology for persistent vestibular symptoms that can come on after COVID. Whenever there are unilateral symptoms, a neurological examination and MRI can be used to determine if there are central and intracranial causes for these symptoms. There are medications, such as meclizine, that can be used for dizziness, but they have functional limitations by masking symptoms. This can actually delay recovery since the root cause of vestibular symptoms is not being addressed. The next section presents information about the clinical management of post-exertional malaise. This slide illustrates how a patient can manage and prevent post-exertional malaise. Using the graph, a patient with baseline activity level in phase A is high, and this is followed by a lower relative management in phase B. This is how patients often present with post-exertional malaise, since their activity level is above their tolerance for physical activity as it gradually decreases. Most patients make an adjustment during phase B of either decreasing or fluctuating activity levels. When there is pacing and self-management of symptoms, as in phase B, patients can minimize their symptoms by keeping their activity level just below their tolerance for physical activity that they had in phase A. This adjustment has patients progress from anaerobic exercise to graded aerobic exercise to increased tolerance as shown in phase D. Physical therapy is considered a mainstay in the management of post-exertional malaise. A typical physical therapy plan of care is to start with exercise 1 time per week for 6 to 8 weeks that includes small intermittent goals to mirror this timeline in order to achieve the long-term goal of an optimal level of function with sustainable symptom stabilization. We will now discuss brain fog and its clinical management. As discussed in Module 3, a majority of the interventions to improve brain fog include self-management, and healthcare providers should educate patients on these exercises. For clinical management, the majority of treatments to improve brain fog are based on treating other conditions that may be contributing to impaired cognition, such as post-exertional malaise and orthostatic intolerance. An often overlooked approach is to promote restorative sleep, as it has been shown to improve working memory, cognition, and attention. Additionally, providers should minimize centrally acting medications and those medications that can worsen cognition. There are some off-label use medications that may help brain fog and cognitive impairment that act through different mechanisms. Providers should be careful in the use of these medications when patients also have post-exertional malaise or orthostatic intolerance. One approach is to use medications for narcolepsy, as these can improve daytime cognition, but they have the risk of increased fatigue as well, so these drugs should be used with caution in patients with post-exertional malaise. Another approach is to use mixed salts of dexedrine as stimulants to increase attention, but there is the increased risk of elevated blood pressure and heart rate, which could worsen orthostatic intolerance. Additionally, since many patients with post-COVID conditions have multiple symptoms and pre-existing conditions, it is important to check if each medication can worsen other underlying conditions. Sleep is important for the management of brain fog and post-exertional malaise. Increased restorative sleep has been reported by patients to improve fatigue, cognition, pain, and mood, so it should be our goal to achieve this for our patients. The overarching goal of getting better sleep is to reduce all causes of sleep disruption and therefore aim treatment at the cause of disturbed sleep. This can range from educating patients on proper sleep hygiene to prescribing medications that can help with the initiation of sleep. It all depends on the individual patient. Getting good restorative sleep is a constant battle, and things that worked at one time may even end up not working later for the same patient. So alternating regimens and reassessing patients periodically become imperative to help achieve restorative sleep. It is important for providers to determine if a patient has a primary sleep disorder based on the history given by patients. Therefore, it becomes imperative that patients should be the ones to monitor their own sleep. It is very much a help us help you situation, so engaging patients in their own sleep health is the best way to promote proper management. Medications that promote better sleep can usually be split into 2 categories, the first being sleep initiators or hypnotics. However, there are drawbacks to use of these medications, as patients tend to develop a tolerance and/or a dependence for these medications. It is better to use these drugs as needed and not prescribed on a nightly basis. It is important to note that these drugs have been FDA approved for the use in insomnia and not specifically in post-COVID conditions. The second category of medications for sleep disturbances are sleep sustainers. These medications help patients stay asleep once initiated. These medications have their own side effects and can create hangover symptoms the next morning if dosed too high or taken too late in the evening. With these two categories of medications for sleep disturbances having their own separate side effect profiles, it becomes important to have a discussion with patients regarding potential for side effects. Providers will also want to consider how other comorbid conditions and the nature of the sleep disturbance before initiating any of these medications.